introduction. So we'll start with CCS 2, and then I will go through 12 of CBS, right? Okay. So um, let's start then. So this was the CCS 2, which the vignette goes like a 62-year female shifted to ICU with shortness of breath since last hour. She was admitted in hospital for fracture proximal tibia, for which a open reduction and internal fixation was planned. This is a known case of diabetes on oral hypoglycemic agent since 6 years. On arrival to ICU, she was afebrile, heart rate of 134, blood pressure of 102 by 56. She is saturating 95% with high flow nasal cannula. She is conscious, oriented, but tachypneic at 35 per minute. So when you have this opening question or opening vignette, you always try to point out what are the important clues in the question, right? So for me, the part marked in red are the important clues. So the patient had a shortness of breath for last 1 hour, which is very, very acute. Okay. She had a proximal fracture of tibia, and ORIF was planned but not being done. Okay. She was tachycardic and tachypneic. So she has broken her leg, but the presentation is pretty acute. It hasn't come uh, with the fracture of the tibia. It has come few hours afterwards, and it was very acute in presentation with tachycardia and tachypnea. When you see this sort of scenario, they're talking about something that has acutely developed, acute respiratory distress with a patient who has a proximal tibia fracture and is planned for a ORIF but not been done. So the question was, what are your differential diagnosis? So importantly, you need to talk about the most probable one and then gradually go down to the least probable one. Okay. So in this case, the answer sheet says the first one is a fat embolism syndrome. The possible second one is a pulmonary embolism. Third one is possibly pulmonary edema. These are the non-infectious causes, and the infectious cause can be aspiration or can be pneumonia, right? I put red in ARDS because most of the candidates were talking about ARDS, right? ARDS is not an answer for sure because the ARDS is a syndrome. Any of these conditions can produce ARDS, but ARDS is not the cause of this presentation, right? The cause of the presentation is fat embolism or pulmonary embolism or pulmonary edema or aspiration pneumonia, right? It's not ARDS. Make sure if you say ARDS, you will not get a mark. 99% of the students were talking about ARDS, right? ARDS is not the answer. The causes are the answer, okay? Now, how do you frame your answer? So this is not only about a hypoxic patient post-trauma. You can be asked many things like someone with encephalopathy, someone with some other syndromic features. You need to have a format to answer the question in the exam beforehand. Straight away, if somebody asks you, what are your differential? You'll talk about only one, but see how many marks are there. 4 marks are there, okay? So only one answer will not give you 4 marks. You need to have a list of things starting from most probable to the least probable one, okay? And for that, you need to have a classification system. Here it is non-infectious and infectious. So before stepping into the exam, make sure that you have some sort of classification system for different syndromes, such as hypoxia, such as acute kidney injury, such as shock, such as fever, or encephalopathy. These are 5-6 syndromic presentation that comes as the initial vignette, and they will ask you about the differential diagnosis. So you need to have a structure to answer it, okay? The second question was, what is your immediate line of management or lines of management, right? So people talk about ABC, intravenous fluid, empiric antibiotic, and consideration of anticoagulation. This is only half of the answer. You have to talk about the investigation. If they talk about management, it is investigation and treatment, okay? There is a way to tell how do you represent your investigation and how do you represent your treatment in the exam. Okay, I'll go in the next slide talking about, first of all, what is the differential diagnosis? How do you delineate a differential diagnosis? If there is a differential asked in the exam, Make sure that what they're asking about, are they asking about in general, not in this case I'm talking about, in general, are they asking about a patient who is encephalopathic or who is unconscious or who has weakness, or the patient has shock or ongoing bleeding, if the patient has hypoxia or patient has low urine output or any other syndromic features, right? So you need to make a classification of etiology or classification of differential so that you can tell in the exam correctly. For example, if somebody asks you about an encephalopathic patient, what is the differential in this case? So you need to have a structure. Make your own structure. It doesn't have to follow this chart. You can make your own structure, but have a structure and put that structure in the exam, starting from most probable to the least probable. If you tell the least probable in the beginning, you will not get a mark. So you have to talk about the first most probable, the second most probable, the third most probable, or fourth most probable, okay? And it has to be in the grid of the answer. For example, for encephalopathy or a unconscious patient, how do you classify the causes, central and peripheral? Talk about central causes. Again, it can be infective or non-infective. Similarly, peripheral causes can be infective, non-infective, metabolic, etc. If they are asking about a patient with weakness, you talk about central, spinal, peripheral, muscle, or other causes of weakness. In that way, you classify your answer. If somebody is seizing and they have asked what are the probable causes of seizure in this case, again, you think of central, peripheral, metabolic, or whatever, any structure, but you need to have a structure from here now onwards rather than making a structure in the exam. Make a structure, practice, and tell it in the exam so that you will get maximum mark in least possible time. Okay. Similarly, they can ask you about shock. What is the type of shock or what is the differential in this patient? Somebody with a shock, what are the differential they will ask? So make a structure of the classification. For shock, it can be cardiogenic, hypovolemic, distributive, or obstructive, right? Similarly, cardiogenic can be infective, non-infective. Infective again can be classified, and non-infective can have various causes such as vascular, drugs, arrhythmia, mechanical. I'm just showing a framework of answer. Okay, hypovolemic can be hemorrhagic and non-hemorrhagic. Similarly, distributic shock can be septic, can be due to neurogenic shock, can be anaphylactic, can be drugs and toxin, endocrine, all those things. So you need to have a structure from here onwards, right? You cannot make that structure in the exam and try to answer. It will take 10 minutes. So make sure that you have a classification system and go to the exam with it. Because the first question in the vignette will be a differential diagnosis, right? Similarly, for hypoxia, you make what are the any type of classification which suits you. Make that classification in your mind from here now on onwards, and then talk about it. Right? I'm not going into the detail of that. This is all over the internet. You can find it, right? Or you can follow this presentation later on in a video. Similarly, renal failure, pre-renal, post-renal, or intrarenal causes. Okay, so in that way you answer. Now, if they have asked about the differential diagnosis, they will ask about treatment, they will ask about relevant investigation. Now, how do you present your investigation? So, what investigation will you advise for this patient? They're talking about what are the battery of investigation that you are going to send. Talk about relevant investigation, not giving a shopping list to them. Okay. And always classify the investigation into three groups: blood, imaging, others, and microbiology if there is a patient who has sepsis, right? So in blood, in this patient, you will send some complete blood count or full blood count, renal function test, CRP, PCT, D-dimer. Imaging, the patient may need a Doppler ultrasound and an echo, and others you need to have an ECG. For patient who is septic or you think sepsis is a player here, you can ask for microbiological culture such as sputum, urine to send. The fourth question was the bedside ECG and echo was done. The ECG showed sinus tachycardia. Echo showed some right ventricular dysfunction with a normal LV systolic function. What is your next investigation? Of course, CTPA. Most of the candidate got that answer correct. Now, CTPA was done. There was no features of pulmonary embolism, bilateral pulmonary infiltrates. What is your differential diagnosis? Or what is your diagnosis? Not the differential. What is the provisional diagnosis? It is fat embolism syndrome. This carries a good number of marks because this is how the case is going to happen next, or they will proceed in line of fat embolism syndrome next. That's why it has carried a good mark there. Now, as I said, always make a classification of your answer. If they ask about investigation, always think in your mind: blood test, microbiological test, imaging, and others. Any special test for that patient. For example, blood test. For this patient, I look for full blood count for a white cell count. I look for other organ dysfunctions such as renal function test, liver function test, and coagulation profile. I'll send some inflammatory markers such as CRP and PCT. Also, if the patient has any cardiac issues, I will do a troponin. If you're thinking it is a pulmonary embolism, also you should talk about troponin. If the patient you're suspecting has a infective issue, then you can talk about relevant cultures and again inflammatory markers. You need imaging for this patient, ultrasound, echo, and CT. Suppose this patient needs some special test. Suppose there is a case of a um, any special test that needs to be sent, meningitis or meningoencephalitis. In those cases, you will do a lumbar puncture, send the CSF for various tests. In that way, always classify 4 types of test and try to fit accurate test in it. Don't give a shopping list starting from, okay, I'll send some full blood count and then I'll send some culture. Then I'll do some LFTs and then I'll look for an X-ray. Then I'll do an ECG. If you go like that, you will not score mark. It has to be a classified system. And the benefit of having a classification that if you are running out of time, you just tell, I'll send some blood test, microbiological and imaging, which includes the blood test include XY. If you don't have time for that, the examiner may skip that. You know the structure, how to answer. They will go to the next question. It does help in the exam. Okay. Now, the sixth question was, what is the criteria of fat embolism syndrome? We are going into detail of fat embolism syndrome now. That's how the scenario will run. So you need to know about few classification. Even if you don't know the classification details inside of the classification, you may talk about some name of the classification if you remember. Even if you don't remember, just talk about the criteria. So most of the classification will have similar criteria, which includes tachycardia, tachypnea, fever, confusion, petechial rashes, and hypoxemia. If you talk about these 4 or 5 features, they may not give you the full mark, but they will give you some mark of it. Few of the candidates were just taken aback by this question and they said, oh, we don't know the criteria. Doesn't matter. You tell them the criteria, I don't remember the exact name of the criteria, but it includes, these are the points in that: tachycardia, tachypnea, fever, petechial rashes, encephalopathy, hypoxia. These are the major criteria that we see. They will be giving 2 out of 3 marks. Don't leave any question unattended, right? That's the basic mantra of passing. Now, give a definitive treatment plan for fat embolism syndrome, right? So make sure that you understand the question. They are talking about definitive plan, okay? Yeah, you can give some oxygen, IV fluid, maintaining a blood pressure of 65 or above. Early fixation of the fracture. Heparin, consider heparin as anticoagulation and corticosteroid, though there is no clear-cut role of it, there is a controversial role. Then the next question asks about 2 precipitating factors other than trauma, apart from trauma, right? I asked this question and half of the candidates were still talking about trauma. So here the question which we are talking about, apart from trauma, what are the other causes that can cause fat embolism syndrome, which includes acute pancreatitis, use of TPN, liposuction, and sickle cell disease, etc. Classical clinical triad of fat embolism, dyspnea, confusion, petechial rash. So they are very fond of asking about triad or pentad or other features of specific syndrome. Fat embolism syndrome, they can ask you about TTP, they can ask you about triad for or varicose triad. So they can ask you about the triangle of death for trauma and coagulopathy. So they're very, or also they can ask you about tamponade. What are the signs of Beck's triad? So they're very fond of asking those 3 points or 4 points in an answer. So make sure that you know about the fat embolism triad, you know about the varicose triad, you know about TTP pentad, which is almost abolished now, but they may ask you about it. So points in there you need to remember, and also tamponade, Beck's triad. Okay, we need to, the day 3 ICU patient remained to be hypoxemic, hemodynamically stable though. She was on subcut heparin 5,000 units thrice a day. The ABG is done, which has a saturation of 92% on high flow bicarb of 20. Other labs have a lowish platelet count, white cells count are still high at 16,000, D dimer is high, and urea and creatinine is both, normal or normal high. HRCT was done as attached. As you can see, patient complained of severe pain in the affected limb, which was not there before, and it was not subsided even after intravenous analgesic. On examination, the limb was tense, and there was a decreased sensation as compared to the other limb. But there was pulse oximeter showing good waveform in that limb. So again, you need to highlight, or you need to make sure that you understand the punch word of the whole vignette. So they're talking about, initially they started with some ABG, which is very non-specific in this case, which can be a what you call attention diverter here. You should attend, or you should focus on the limb, right? And the pain doesn't subside with intravenous analgesic. That means it is a pain out of proportion, okay? And you feel the limb which is tense, and there is decreased sensation. So there are few signs which suggest that there is something grossly wrong in that limb. And the CT scan here may be just a bystander. So they're talking more about the limb and the decreased sensation. So in this case, your question can go either way. They can talk about the ABG, they can talk about the limb, or both, right? Let's see what happens next. So what can be the cause of severe pain in the leg in this patient, right? Again, you need to think about how many differentials and how many mark. It is not one. So they are asking about the possible causes here, right? The most probable case is acute compartment syndrome of that limb. The others can be DVT, cellulitis, or acute limb ischemia. These are the possible four causes, or any relevant answer that fits in the probability of answer that will give you a mark. Don't stop with one answer, right? Now, what will be your immediate investigation in this case? Think clinical always. What will you do at the bedside if the patient has such symptoms? So first of all, you will do some imaging. You will ask for some blood test. And if you're thinking the patient is going to theater, what are the other things we need, right? So imaging, venous and arterial Doppler, yes, you need to do it. What are the blood tests you need to do? So you definitely need a CPK level. You may look for a renal function test because that's what rhabdomyolysis can cause. You can look for urine analysis and urine myoglobin, which is rarely used, okay? And if the patient you're thinking needs surgery, then what is the most important thing that you do is a coagulation test. Make sure that the patient is not coagulopathic going into the surgery. As the Doppler were normal, acute compartment syndrome was was the provisional diagnosis. And what are the criteria of acute compartment syndrome? Again, this is an important part of the question because the management lies on your accurate diagnosis, and they want the criteria for acute compartment syndrome of a limb. Okay. So the 5 or 6 P's that we do: pain, paresthesia, poikilothermia, pallor, paralysis, and pulselessness. If you can tell that, you'll get the whole mark. Even if you forget any of the P, just talk about what you see, right? Significant extremity pain which is out of proportion to the injury. Pain and other features rapidly progresses over a few hours. The compartment feels tense. The pain exacerbates by passive stretches of the muscle, and compartment specific neurovascular finding, which includes again the same thing: decreased pulses, muscle weakness, and paresthesia. So any of the P's, the more number of P's you say, the more number of marks you'll get. So very important clinical diagnosis. Now, people, when I ask them about what is the indication of fasciotomy, they only stopped at saying that the delta pressure less than 30 is the indication. Yes, that is the indication, but there are other indications. Even if the delta pressure is more than 30, if you have these clinical symptoms, fasciotomy is the treatment. Okay, you cannot wait for the delta pressure to come below 30. So I'll go to that question next. Okay. Now, what is the delta pressure and what is the cutoff value? So delta pressure is the difference between the diastolic pressure and major compartment pressure. There are various articles you can see. If it is less than 20 or less than 30, it needs emergent fasciotomy. That's in the context of a delta pressure measurement. How do you manage a acute compartment syndrome? Again, See how the scenario has evolved. It started with the fat embolism syndrome as a gross abnormality, then very focused on the limb ischemia. Now, in this case, acute compartment syndrome, I asked people what is the management plan. They were again starting with ABC, which will not give you a mark. Yes, that is a correct answer, but you have already done that. Initial resuscitation, fluid volume given, targeting a map, targeting some sort of saturation. You have already done that. There's no point repeating that here. This is a compartment syndrome. They're asking how do you manage this case, right? So you classify your answers saying there are some general management, there are some specific management, and there are some experimental therapy, which I don't expect most of the candidate may not tell or may not remember this. But always classify saying there's some general management, there's some specific management. The general management includes further serial examination of the limb. If there are any pressures causing thing like a bandage or something, remove it, supplement oxygen to the patient, give adequate analgesia and IV fluid, and avoid hypotension so that you maintain the perfusion of that limb. That's the general management, okay? But specific management is most important. You need an immediate surgical consultation and consider fasciotomy. The experimental therapy, but not acutely, where you can use hyperbaric oxygen in these cases, okay? Indication for fasciotomy, that's what the first indication is for high clinical suspicion. If you have a very high clinical suspicion of compartment syndrome, even if the compartment pressure are more than, even if the delta pressure are more than 30, if you have a high clinical suspicion, you go ahead with fasciotomy. You don't wait for the delta pressure to fall below 30. Okay. Of course, the other indication is compartment pressure less than or delta pressure less than 30 millimeter of mercury. All right. So we need 3 again. As the patient becomes tachypnic, she was she was put on non-invasive ventilation. The lower limb swelling gradually decreased with conservative management. On ICU day 5, patient develops gross abdominal distension and was unable to pass stool for last 5 days. So, important thing, the leg swelling has resolved. She is on non-invasive ventilation and there is gross abdominal swelling or the gross abdominal distension, and he or she hasn't passed any stool for 5 days. Now, straight away, I think most of the candidate can think that this is going to be some abdominal catastrophe that is going to happen, and the questions will be asked on that, right? So just preempt that yes, it is going to be asked. So think of what are the possible questions in there. I would request someone who is scratching on the screen, please delete that. Otherwise, candidates will get distracted with it. All right. On examination, she is still tachycardic. Her blood pressure is okay. She is saturating 95% on non-invasive ventilation with a pressure support of 12 and a PEEP of 6, FiO2 of 0.45. Her GCS is 15. There is bibasal crypts on auscultation. The abdomen seems distended, tympanic on percussion. Bowel sounds are sluggish, and she hasn't opened her bowel since last 5 days. Especially in last 2 days, nothing has happened. Um, lab investigation, hemoglobin white cell count slightly raised. The platelet count is decreased to 76,000. The creatinine is high normal. Sodium, potassium is very low. Magnesium is satisfactory, and calcium and rest of the examination is normal except for the blood glucose, which is high, right? So in this case, somebody has abdominal distension, has bibasal crypts, hasn't opened his or her bowel for a few days now, which is tympanic on percussion, and has a low platelet count. So how do you and a potassium level of 2.9? How do you link them together? In this case, I think abdominal distension with a low potassium is because of an ileus. Okay. So the question is, what are the causes of abdominal distension in this case? Again, think broad. Sorry, I think I have messed it up. The first one was bit, sorry. These answers came from the previous question. Anyways, what are the causes of abdominal distension? Again, you keep your answer broad. So don't go straight away saying only ileus. So don't bother about the yellow column. We'll discuss in anyways. So don't talk about straight away about only saying that oh it is a pseudo obstruction or it is a ileus. So talk about broad and then narrow down. Okay. The first most probable diagnosis is a colonic pseudo-obstruction or a Ogilvie syndrome. The other possible causes can be it may be due to ongoing ileus. It can be due to any perforation peritonitis, or it can be due to because the patient looks like has diabetes with a high blood sugar that can cause a atonic bowel in that case. It can be due to infective causes such as C. diff or toxic megacolon due to C. diff, right? Or into susception. So hard to say which one is it, but most likely it looks like a colonic pseudo-obstruction due to hypokalemia and ongoing hypokalemia in this case, right? So you keep your diagnosis broad. Just do not say only Ogilvie syndrome or a colonic pseudo-obstruction. Yes, that's the most probable or provisional diagnosis, but also give 3 more so that you can get marks, right? How do you further investigate? Forget about this investigation because that was from the previous question, got copied here. How do you further investigate this case? So what you do usually in this case? So you do first a plain X-ray of the abdomen, make sure that there is nothing wrong. Okay. With the conservative management, if the patient is not getting better, what will you ask for? You'll ask for a CT abdomen with or without contrast, depending on the renal function and the indication. So these are the 2 things you look for, right? And also look for other blood investigation which you have done already, the potassium level. Okay, that's very important, potassium magnesium level, and make sure that she is not on any um, drugs that can delay your gastric emptying or delay your bowel movement in those cases. So investigation wise, you do first do some blood test which includes the electrolytes, and then imaging which is a CT abdomen with or without contrast based on the clinical indication. What is a provisional diagnosis, right? Only one, which you think acute colonic pseudo-obstruction or a Ogilvie syndrome. How do you manage, right? Again, talk about management, always talk about general management, specific management, or if there is anything experimental to be done, right? So general management in this case, correct the hypokalemia. If there is any hypomagnesemia, correct it. Stop any narcotics if there are confounders to that. Think of early ambulation of the patient, physiotherapy, and control blood sugar. Specific management will be drug treatment, try some metoclopropamide and/or erythromycin or and/or neostigmine depending on the clinical indication. Also, what are other intervention you need to do? Put a nasogastric tube, if possible, put a flatus tube, and consider colonic decompression if everything conservative fails, right? So that's how you answer your management part. Now, what are the role of colonoscopy? So when they ask about what is the role, think in a different direction. Is there a diagnostic role? Is there a therapeutic role to it, right? So diagnostic role to rule out any distal obstruction, or if there is any cause of obstruction there, a tumor or a mass or something, right? And therapeutic is therapeutic decompression of the colon, which is again controversial, but it may be needed or it worth a trial if your conservative management is failing. Now, what are the investigation of surgery? Again, if there is persistent colonic dilatation even after colonoscopic decompression, if there is a complication due to the colonic dilatation, which includes a perforation, or if there is abdominal compartment syndrome, in those cases, we go for surgery in this case. So very clear-cut indication for the surgery, right? Okay. Now we need 4. So ICU day 8, patient developed fever and tachycardia, started on noradrenaline infusion to maintain a MAP. Relevant cultures were sent and started on antibiotic, which include meropenem and teicoplanin. Now the patient is able to tolerate off non-invasive and maintaining saturation of around 96% on nasal cannula of 2 liters, but she continues to be drowsy and rousable, right? She is drowsy but easily rousable. Urine output gradually decreased with 30 ml of urine per hour for last 4 hours. Her lab showed a TLC of 23,000, or leukocyte count, low hemoglobin. Platelet counts are progressively getting less and less. The INR is deranged now at 2.2. Creatinine is raised with 2.2. Again, sodium is 129. Potassium is slightly on the hyperkalemic side. Bilirubin at 5.1, SGOT and SGPT is slightly raised, GGT is slightly raised. She has relative hypoglycemia, and the chest X-ray looks better than earlier. The ABG shows a pH of 7.31 with a PCA2 of 27 and a BICAR of 16, so metabolic acidosis, and the lactate is 3.6. So in this case, the patient, they call the catch point are she is drowsy but rousable. Her urine output has progressively decreased compared to earlier with a raised lactate and metabolic acidosis. Again, they will ask you, what are your differentials here? Or what is the biochemical abnormality to start with? So this is a very easy question, but make sure that you talk about every abnormality that you see in this case, such as a high leukocyte count with anemia and thrombocytopenia. The patient is coagulopathic with a renal failure, with relative hyponatremia and hyperkalemia. There is mild derangement of or there is mild transaminitis in this case, and the patient is hypoglycemic. The ABG is consistent with metabolic acidosis with a lactate of 3.6. So that's the complete answer. Now, what are your differentials again? In this case, patient who has worsening renal failure, who has decreased urine output, who has metabolic acidosis with a lactate of 3.6, it's either sepsis or something related to bowel. There's not many issues that can cause that type of picture. So sepsis with multi-organ failure because the patient has fever. The other possible cause can be bowel ischemia in the background of colonic dilatation or Glebe syndrome. So that can be the other differential. But any relevant other explanation, if you can give, that can be taken as an answer because it will be in the grid. Now, what are the diagnosis or what are the indication of dialysis in this case? So this is again a very important question. Mostly asked, what are the indication of dialysis? Always think of 3 or 4 things, right? First is metabolic acidosis, dangerous hyperkalemia, uremic symptoms, fluid overload. There are 4 very strong indication for dialysis in any patient. If the patient is fluid overloaded, if the patient has worsening metabolic acidosis, if the patient has non-responsive hyperkalemia, and if the patient has uremic complication, which includes encephalopathy or uremic pericarditis, right? So these are the important indication for dialysis in any case. What type of dialysis is we will prefer and why? So of course, CRRT or SLED because the patient's hemodynamics are more stable in CRRT. That's why we select this modality. We need 5, just to twist a bit more. The patient was thrombocytopenic there, right? So SLED was started in view of worsening metabolic acidosis and hemodynamic instability. Patient was intubated in view of poor GCS, probably septic or metabolic encephalopathy. This is she was maintaining on 40% oxygen with a PEEP of 6. And she who was on a fentanyl infusion in urine output was 20 ml per hour since onset of dialysis and was on 10 microgram per kg, 10 microgram per minute of noradrenaline infusion. The ABG again shows a moderately high lactate with a high sodium 154 and normalish value for potassium and a bit of a low PCO2. In the morning round, the resident doctor was happy about increased urine output in last 2 hours, so 120 ml per hour. So something has happened that has pushed the urine output a little bit higher. And the pupil were not equal. The right pupil are 4 millimeters sluggishly reacting, and the left was 2.5 millimeter reacting to the light. Both are reacting, but the right one is larger and sluggishly reacting. So all this finding represents there's something wrong in the brain, okay? And then you see this CT scan. The CT scan shows some blood in the Sylvan fissure on the right side, and there may be some subarachnoid blood also. You can see in there also. So the question is asking, what are your diagnosis or abnormality that you can see? In this case, again, I have already repeatedly told that if there is a CT brain, you always talk about the findings or always look at 5 or 6 things in the CT brain. First of all, if it is a trauma patient, look for any fracture in the skull. This is not a trauma patient, so forget about that. Don't have to. Then look for any signs of cerebral edema. Yes, there is no gyri or sulci seen here prominently, so there is a component of cerebral edema which looks like there is definitely diffuse cerebral edema with loss of gray white matter differentiation. Then the third thing you look for is midline shift. Is there a midline shift? No, there is no midline shift. The fourth thing you look for, any hemorrhage. If it is there, where is it, right? So you can see there is a Sylvan Fisher blood there, so subarachnoid blood, and there is no localized hematoma, but there is some blood in the subarachnoid space. Fourth thing. The fifth thing is signs for hydrocephalus. If there is any dilatation of the ventricle. So there is no signs of hydrocephalus. But again, those 6 or 5 things you have to put it into context. So this is a patient who has deteriorated, no history of trauma. And what you can see here is there is loss of gray white differentiation, diffuse cerebral edema without midline shift, and there is evidence of subarachnoid blood. There is no signs of hydrocephalus. So these are the important findings that you have to tell if they are asking about the question, right? So diffuse cerebral edema with cysternal subarachnoid hemorrhage. These are the most important finding in this case. What is your immediate management plan, right? People were talking about many things here, but what you do practically, if you see blood in the brain, call the neurosurgeon, isn't it? That's the basic idea we have. So first answer, call the neurosurgeon for a consultation, right? Now there are signs of raised cerebral, or there is signs of cerebral edema or raised cerebral pressure by looking at bilateral unequal pupils. So in that case, that qualifies for hypertonic therapy, whether mental or 3% saline. Then usual neuroprotective strategy, which includes head and elevation, hyperventilation, making sure that the patient is sedated, well sedated, and probably if you need to be paralyzed, and looking for a low normal PCO2 in the range of 35 or 34 to 37 in that range. Okay, so these are the neuroprotective strategy they can ask for. So this question can go in that direction also. What are tier 1, tier 2, tier 3 therapy for raised ICP and all those things, right? Now the next question was, what is or are likely etiology of sudden deterioration in this patient? So uh, you think of the question, what we are asking is why the patient deteriorate? What is the cause of it? So either it is hypoxic ischemic encephalopathy or worsening hypotension causing compromise to the brain circulation. These are the two reasons why the patient has deteriorated in this case, right? Subarachnoid blood doesn't cause encephalopathy as such. The complications of that causes it, right? Whether it is hydrocephalus, whether it is a mass effect, whether it is cerebral edema, all these can cause encephalopathy in a subarachnoid hemorrhage, right? So if you ask what is the etiology of sudden deterioration, it is not the subarachnoid hemorrhage. It is the complication of that, which includes either hypoxic ischemic encephalopathy, or either it is hypotension related to compromised circulation to the brain, or it is cerebral edema, right? So in that case, your answer should be what is causing the decreased consciousness in this patient. Now, at the end, they will ask about some counseling or some non-clinical stuff in here. In this case, one of the family members ask you about the outcome of the patient. How will you explain? Right. They are not looking at your content of your answer. They are looking at an approach. So make an approach. If this such situation or such questions are asked, to talk about the principle, right? So we'll follow the usual spikes principle. If you say that, you get the mark, right? Now I will make sure that the setting is adequate. The patient or the family member I'm talking to has the perception or the right perception. I will check his or her knowledge. My approach will be much empathetic to the patient. I will give the option to involve other family members if the patient's relative wants it. And then I'll start with a summary of the case, making sure that all bits of the summary is understood by the family members, and then gradually build up my conversation, looking at explaining that the patient has currently is critical and the outcome looks very grim in this case, but the management strategies are ongoing and we will update the family as things progresses, right? So that's how you look for counseling or look for updating the family. Always talk about the principle. So I'll talk about my approach will be the spike standard, which includes get, as I said, the same thing. I don't want to repeat it, but you need to tell the approach type, the spike standard, because this is bug standard for the European exam. Okay. Now that completes the CCS. Suppose, are there any there are two questions in the chat box? Ambulate her for getting. Yes, you. Yes, definitely. If you have a fasciotomy done, that should not prevent you from ambulation. Yeah, so fluid overload is not there. Yes, in general, we talk about the question of dialysis was indication of dialysis in general, but everything doesn't have to be in the vignette. So you need to talk about because there is very specific answer to what are the indication of dialysis. There are not more than four in clinical science, right? So it is either fluid overload, hyperkalemia, acidosis, or uremic complication. These are the four things. Hydroflu, what does that mean? Vasospasm, yes, but when do you see the vasospasm on day one? Highly unlikely, right? Dialysis disequilibrium, yes, but with CRRT very rarely. Hydrocephalus, answer is no because you can't see hydrocephalus in the CT scan. It is not there. Okay, I'll go ahead with the CBS. So the first CBS, yeah, somebody told me, sir, MRI is not asked in the exam. Yes, it is not asked in the exam. Even if I don't give this picture, you should be able to answer the question here. The 76-year-old male hypertensive patient was taken into hospital by the nearby family member with complaints of drowsiness for 5 days. He was found to have a serum sodium of 114, which is low, which which he was started or was started corrected by emergency department and shifted to the ICU. The next day, he was found to be quadriparetic, poor cough reflex. Repeat sodium was sent. It was 141. MRI done, which showed the above, right? So there is an increase in serum sodium by um, more than 25 points or 28, probably 27 points there, which is a very rapid rise within 24 hours. So with the MRI showing diffusion restriction in the pons area, it is nothing but a central pontine or extrapontine myelolysis. Um, you don't need the picture here. The clinical vignette is such, as such says that this is the cause rather than looking at the picture. So what is the radiological finding? So FLAIR image showing classic trident shape of the pontine with signal hyperintensity suggestive of demyelination. Most probable diagnosis in this case is CPM or osmotic demyelination syndrome, either of that. Next line of management. All right. In this case, airway breathing circulation or taking care of airway breathing circulation, the treatment is usually supportive, but we should look to reverse the sodium level to a safe level, right? So it is being shown that in some like not very good robust evidence about it, but if we reverse the sodium rise in rather quickly, suppose on day one, if the sodium has gone more than 20 or something and the patient starts to have some symptoms, then we can reverse the rise, make the sodium go down um, rapidly to a safe level, like 114 to 118 possibly. In that case, that has shown some benefit of outcome, but they are all very small single center or very what do you say non-validated trial, but it has shown some benefit. So reversal of sodium level is another treatment modality. Again, 50, again, few of the candidates say, oh, so we don't know the EEG. Yes, you don't need to know the EEG even in this question. 50, so EEG has few patterns that is you are expected to know a triphasic pattern, what is alpha wave, what is beta wave, and how do you look at them. But they will not give you usually epileptiform EEG, something abnormal, either a triphasic or a burst suppression. These are the two things that can come as an EEG, right? So 57-year-old alcoholic, that should ring the bell. Alcoholic, hepatic encephalopathy. What sort of EEG you get is a triphasic waveform, right? Was found unresponsive and taken to hospital. Non-contrast CT, negative for hemorrhage. Complete blood count and basic metabolic profile was normal. On examination, wakes up briefly to painful stimulus, grunts and moves all his extremity equally. He is afebrile, no nuchal rigidity noted. The EEG shows as here. So identify the EEG. It's a triphasic waveform. What is the likely diagnosis? Hepatic encephalopathy. How do you treat? Is again taking care of ABC. Specific treatment includes lactulose, or you can give some anti-ammonia measures, which includes say, rifaximin or CRRT if the ammonia levels are dangerously high and the patient has worsening hepatic encephalopathy. Ultrasound of the Doppler. So 68-year-old male admitted in subarachnoid hemorrhage. On her ninth day of a hospital stay, acutely develops right arm weakness and slurred speech. The following transcranial Doppler of her left middle cerebral artery is shown. So nobody will give you a normal TCD there. It has to be a increase in middle cerebral artery, which you can see around 250 centimeter per second, which is significantly increased. Identify the abnormality is the elevated velocity during the diastolic flow, which is suggestive of cerebral vasospasm. What is the next most definitive investigation? What do you do? DSA, or you can say CT angio, CT or a DSA. These are two acceptable answers. How do you treat? So hydrate the patient, like make sure that the patient is not hypovolemic, maintain a higher MAP, and also intraarterial calcium channel blocker or other vasodilator, and start enteral nimodipine whenever you suspect vasospasm, or empirically you can start on day 2, day 3, whenever it is feasible. So there are four important points of management. So hydration, maintain a higher mean arterial pressure, intraarterial vasodilator, which includes the calcium channel, milrinone, etc., and enteral nimodipine. This is optic nerve sheath diameter. So 38-year-old male came to emergency, traumatic brain injury, and he was intubated due to low GCS. Initial CT showed severe traumatic brain injury. In ICU, he developed unequal pupil with bradycardia. Immediate bedside ocular ultrasound done, which shown the following image. The size is more than 6 millimeter, as you can see, 6.6, which is suggestive of raised ICP. What is your diagnosis? Raised ICP, as the diameter is more than 6. Immediate treatment, again, hyperventilation for a target PCA2 of somewhere between 32 to 36, head elevation 34, more than 30 degrees, and hypotonic saline or mantle. X-ray. So 55-year-old patient was on a mechanical ventilation for COVID ARDS, finished 3 cycles of pruning and now better oxygenation, even when supine. Suddenly the patient started to develop hypotension with high air pressure, alarm and ventilator. The chest X-ray, even if you don't see the chest X-ray, the clinical vignette says that probably he has a pneumothorax with tensioning. The chest X-ray was taken and suddenly had a cardiac arrest and CPR was ongoing. Diagnosis: tension pneumothorax on the right with mediastinal shift, mild to the left. What is the immediate step? Needle decompression or intercostal drainage tube placement. So you will share. The appropriate answer should be needle decompression. What is the equipment? This is a Hemlich's valve, which used as a unilateral valve for air leak from the lung or bronchopleural fistula, which is used in mobilization of the patient. You don't need a water seal for this, right? Hemlich's valve. Few people struggle with that, but this is very straightforward. So bronchoscopic percutaneous tracheostomy, you can see the guide wire and also you can see the dilator coming in there, right? Okay, 3-bottle drainage system. So identify, this is a 3-bottle drainage system. What is the purpose? The first one is the collection chamber, second one is the water seal, third one is the suction control bottle. So these are the 3 characteristics of the 3-channel system or 3-bottle system. Nobody answered this one correctly. So identify the equipment. This is not a high flow device. This is a humidifier, right? Active humidifier. What is the ISP? That is called as the isothermal saturation boundary. This is a term used to locate a point in the airway where your inspired air becomes isothermal with the body temperature and acquires a relative humidity of 100%. So our air has a relative humidity around 40-50% that we inhale, but it goes through our nasal passage, then to the pharynx. It gets humidified and gets warmed to the extent that it resembles the body temperature and gets a relative humidity of 100%. That is somewhere around where 5 centimeter below the carina, right? That's the isothermal saturation boundary. If you don't use a humidifier, that isothermal saturation boundary will be very, very uh, distal, thereby the airway will be dry. They will not have adequate vapors or water vapor that can cause impairment of the ciliary activity and also can cause further drying of the secretion and further complications. So that's called as the isothermal saturation boundary, which is 5 centimeter below the carina. 30-year-old lady diagnosed with CML blast crisis. TLC count is 1.8 lakh. She was feeling little dyspneic, though room air saturation of 100%. Now, so this patient has a room air saturation of 100%, but a SaO2 80% and a PO2 35. So something is not collaborating or not correlating. So interpret the ABG. The ABG has hypoxemia and has some respiratory alkalosis with a low PCO2. What can be the cause of this abnormality? So it can be a mixed venous gas where it has mixed with something. It can be pseudo-hypoxemia or it can be leukocyte larceny, right? So spurious hypoxemia on the ABG, which is the consequence of ongoing metabolism of the oxygen by the blast cells, which is very high. They consume the oxygen. A drop in PO2 up to 72 millimeter mercury is noticed. So if you take a blood gas and if you have white cell count in the extent of lakhs, then within the transport time from the bedside to the ABG, if it takes more than 2 minutes, then your PO2 will decrease by up to 70 millimeter mercury. And but in this case, the peripheral oxygen saturation will remain the same. So that is the diagnostic part. The peripheral oxygen saturation remains the same, but the PO2 is low, which is not correlating clinically also. There's a table here which looks at true hypoxemia, leukocyte larceny, carboxyhemoglobinemia, and methemoglobinemia, and what happens. So you can look at this table, readily available in the internet also, or you can refer to this video and make sure that you don't miss that, because methemoglobinemia, leukocyte larceny are very, very important question, and cyanide toxicity, important question in the exam. Make sure that you know the biochemical abnormality, ABG differences in that. All right, ECG. Few people struggle with this actually. 40-year-old lady follow-up case of carcinoma ovary on platinum-based chemotherapy. So there are flags in the question. Carcinoma ovary on chemotherapy, come to emergency with acute onset chest pain. It is a P. If you hear about this, carcinoma ovary with chest pain, it is a P, right? That's the first diagnosis that comes into your mind. Last 3 days with mild shortness of breath. Chest pain does not have any localizing feature, no exacerbation with movement, breathing or cough. Chest X-ray is normal. Again, normal chest X-ray with tachypnea is a P. 2D echo is normal. ECG shows this, right? So what does it have? Sinus rhythm, right axis deviation, right bundle branch with S1Q3T3. Only 20% of the cases will have S1Q3T3 for a PE. Not very diagnostic of that, but sinus tachycardia is an important part. This one doesn't have a sinus tachycardia, but if you have a sinus tachycardia, that is again a suggestion of PE. What is the diagnostic option? So CTPA, lower limb venous Doppler, echo or VQ scan, right? Any correct answer will give you a mark, but we'll go with CTPA to start with, right? Now, this one was discussed in our cardiology part. So very simple way of looking at a ECG. How do you look? I look in a syndromic manner again. So if you are getting an ECG in the exam, not in real life, in the exam, the ECG has to be normal, probably 99%. Now, what are the abnormality you have? Either it is a ECG with arrhythmia or peri-arrest rhythm, or it has a ischemic rhythm, or there is some metabolic abnormality that is showing that rhythm, or if there is a pacemaker rhythm, or if there is a syndrome associated with that. There are 5 types of ECG abnormality that is usually asked in exam. 95 to 99%. Your ECG will lie in these 5 types: arrhythmia or peri-arrest rhythm, ischemic rhythm, something about metabolism or metabolic abnormality, that may be a pacing rhythm, or there may be a syndrome. So arrhythmia, you know, AF, A flutter, V tag, V fave. supraventricular tachycardia, R on T phenomena. Ischemic rhythm, you know the distribution of the arteries. That's the diagram for that. I'm not going in detail. You should know about it. Distribution of the artery, and you look for the changes and reciprocal changes. Metabolic rhythm, QT interval, right? Hyperkalemia, hypocalcemia, hypomagnesemia, and TCA toxicity. These are the metabolic rhythm they usually ask. And the pacemaker, like pacing failure or sensing failure, then tachycardia, so pacemaker induced tachycardia. These are the things they can ask about pacemaker rhythm. And if you find that nothing is fitting in this, is this a syndromic rhythm, which is like a Wallenstein or a Brugada syndrome, or a short QT or a long QT syndrome, or a WPW syndrome, or a pulmonary embolism type of picture, or the patient has pericardial effusion with short QRS and variation there, or the patient has dextrocardia. Remember, dextrocardia is very, very important in the exam. Make sure that you don't miss it, right? So always look at the ECG in that way. Is the rhythm is normal? Yeah, the rhythm looks normal. It is not an arrhythmia. Is there any ischemic changes? No, there is no ischemic changes. Is it is it uh, is it like a pacing rhythm? No, it is not a pacing rhythm. Then what I'm left with here? Either it is a metabolic syndrome or some sort of congenital syndrome. Now the patient will have hypokalemia, hypocalcemia. Does the patient history says that? If no, then it is a syndromic, whether it is a WPW, Brugada, or it is a Wallenstein or something in the syndromic group. So that's how I look at it. But you are welcome to have your own way of looking at it, because you'll not get time in the exam if you start. Oh, okay, axis is correct, PR interval is normal, QRS is abnormal. In that case, very difficult to delineate in a minute about the ECG, because if you concentrate on the ECG for 2 minutes, you will lose another two questions down the line. Okay. All right, next one is 45-year-old lady undergone total colectomy, has admitted to ICU for observation on post-op day 1 or 0, sorry, post-operative day 1. Clinically, patient is absolutely stable, room air, adequate urine output. One fellow does an ABG, so everything is normal. Then the ABG comes as abnormal, right? With a PCT of 20, PO2 of 82, lactate of 0.7. And bicarbonate of 13 with a base excess of -11, right? Interpret the ABG. So normal patient, abnormal ABG with normal findings on the monitor. It is a spurious ABG, right? It shows severe metabolic acidosis with a normal pH. How do you explain that? It is probably a diluted sample due to excess heparin. The pH is maintained due to the buffer present in the blood, and carbon dioxide gets diluted with the heparin. The bicarbonate is being calculated. It is a calculated value from PCO2. So if the PCO2 is low, the bicarbonate comes as low, and the pH also as alkalotic, and have a spuriously low value. So this is heparin diluted sample in a patient who looks normal, monitor is normal, but the sample is wrongly collected. Okay. 55-year-old man after uneventful thoracotomy and esophagectomy develops confusion. So thoracotomy, esophagectomy, important esophagectomy part, right? Confusion, ocular abnormality, and incoordination on day 4 of the post-op. Following biochemical results were noted. As you can see, potassium is slightly low, phosphate is low, just low normal. Urea is also low normal. Creatinine is again low normal or very low in this case, and magnesium is low. So not enough to tell that it is a refeeding syndrome. Few people were talking about refeeding syndrome. I don't know why. The presentation is confusion, ocular abnormality, and incoordination. Something neurological which is related to these tests, right? The patient has esophagectomy, probably malnourished, because the esophagectomy guys are usually malnourished. What deficiency they can have? They can have thiamine deficiency causing 1X encephalopathy, which has the similar symptoms like confusion, ocular abnormality, incoordination. The similar thing can come with a patient with alcoholic who lives on only fish and chips, doesn't eat much, or who lives on only liquid diet. All those are very important point in the question. So esophagectomy, malnourished, alcoholic, on liquid diet, prolonged stay in the ship, all those things, or a vegetarian person, all those clues uh, takes you towards a Wernicke's encephalopathy, right? So what is a medical emergency? So it is a medical emergency, Wernicke's encephalopathy with dyselectrolytemia. How do you manage? Thiamine, electrolyte supplement, and gradual buildup of nutrition. Um, I will probably stop here to give Tapas the next question to work on. Dr. Tapas, are you in there?
Yeah, I am here. So I would first take the feedback of all the candidates till now. Anyone
All
who wants
right.
to share anything for Dr. Sanant? Any queries? I have
Uh,
gone through the chat box questions, so I have tried to answer, and there are certain the options they have tried to answer. So it's okay.
so
You can try with
Yeah, DSA, yes, DSA is the management of choice for subarachnoid hemorrhage, no doubt about it. But at some centers, they can do a CT angio also, depending on the time of the day, depending on availability of the facility. So DSA is correct. Which other intra-arterial vasodilator can be used? So various things have been used. So verapamil, papaverine, um, um, what is that? Milrinone, all this can be used. Again, DSA, yes, DSA is the first choice. Evidence showing only enteral nimodipine has, yes, correct, rather than, yes, you are correct. So that's why I didn't talk about triple S therapy. I told about maintaining hydration, that is euvolemia, hypertension, right? Hypertension definitely has a role, but doesn't have hypervolemia, doesn't have a role, or giving like what do you call the viscosity of the blood to reduce the viscosity doesn't work. So only therapy does work is hypertension and euvolemia, not hypervolemia even. You are correct. Old triple H is not in account, but definitely hypertension and euvolemia. That's why I have written as what do you call hydration, not hyperhydration or not hypervolemia. Intra-arterial vasodilator like CCB is used in isolated case, though evidence is not robust. That's because it is a newer therapy. That's why the evidence is not robust, but it is a standard of care in most of the hospital. At least where I work, which part of the world I work, it is a
Yeah,
standard
I
therapy
have
for
actually
treatment of.
written that because there was a query. Yeah,
Yeah,
this can be used. Yeah, you have to answer
yeah.
in the European countries that they
Hypophosphatidemic
can
after
use.
ICU find out this is. Yeah, refeeding. Yes, it can be refeeding, as I said, but refeeding usually presents as a different type of feature. It doesn't have neurological symptoms such as ocular um, abnormalities or confusion. They present with tachycardia, they present with rhabdomyolysis. These are the features of refeeding. Usually, they don't present with ocular manifestation or confusion or neurological signs. Refeeding can be, but how do you explain the ocular abnormality and confusion in the context of refeeding is difficult to say. That's why Wernicke's encephalopathy is an emergency. That should be the primary diagnosis, not refeeding. All right.
Yeah. So, Dr. Sanant, can you stop sharing,
Yes.
or else,
No.
yeah, it
I've
will be
stopped
better.
sharing. Sorry, go.
Yeah, perfect. Okay. So, yeah. So the whole idea here that the CBS questions are actually mark fetching, as well as also slight. You have to plan your timing properly. Otherwise, what will happen? You will be losing your time just thinking about few questions, because there would be almost 10 to 12 questions, CBS question in one station. So you have to go in tandem. You cannot stop for one question, two questions, and take almost 50% of your time. So that will definitely reduce your options or your chances of clearing the exam, because CBS is one of the most important domain out of the two domains that would be something people are scared of, because we have taken the feedback of our last four batches. So everybody feels that CBS is the station where they face the most important difficulties in their exam. So just continuing further, the question number 14, everybody knows what is the waveform. If you do not know or you are a little bit confused, please be prepared that this is one of the most important domain of your CBS or CCS. Because if the CCS question, one of the clinical vignette may be that would deal with the cardiogenic shock, and they will definitely keep one scenario, one picture, one graph about your IABP. So we have deliberately kept it in our last CBS in the last 25 what is we are now discussing about IABP. So here, what is the augmentation ratio? So it is 1:1 augmentation. You can see, and how do you check the adequacy of augmentation? I would be making it very clear that related to IABP, you have to know from A to Z. There is no option. You are getting a question that can be related to anything. So that's why we have deliberately kept little bit theory about the IABP, and the indications. This picture says it all, that it is inserted to reduce the afterload and increase the cardiac output. And you have to see that the diastolic augmentation is at least 30 to 70% of the previous, like the the question asked the adequacy of augmentation, so it has to be 30 to 70% higher than the assisted systolic blood pressure. So, and you can see here the exact position that would be helpful to see whether you are inflating it at the right time, at the right position. So now you can see here, it would increase the diastolic blood pressure as well, and also increase the coronary perfusion. So if you see, there are four important things that is happening here. It would decrease the afterload, it would increase the cardiac output, it would increase the diastolic blood pressure, and it would increase the coronary perfusion. So that is the problem that happens in the cardiogenic shock or the patient having failing LV. Now, this is the midpoint of the T wave. That's the position at which you have to trigger your balloon inflation, and the peak of the R wave, you have to trigger the balloon deflation. Now, you can see here, the goal, I have already told, the final goal would be to increase the myocardial oxygen supply and decrease, as a result, it would be decreasing the myocardial oxygen demand. So that question can keep any of the options. What would be the, or like the time at which it should inflate? What should be the time at which it should deflate? What should be the ECG? Like the graph would be there, and you have to identify whether this is actually happening at the right time. What are the indications, what are the goals, what is the mechanism of action. They can make permutation combination of any of the situation, any of the important points. So that is something related to IABP. And moving further, the indications, here we have tried to like keep all the important points: severe LV dysfunction, post MI, if the patient is having either of any of the options, complications like the mitral papillary muscle rupture, severe acute mitral regurgitation, acute VST rupture, and acquired VST. Then any patient who is having difficulty weaning of your cardiopulmonary bypass, a long cross clamp time, partial revascularization, pre-existing myocardial dysfunction. Then anyone who is having heart failure, cardiogenic shock, not refractory to the pharmacologic management. Actually, it is refractory to the pharmacology management. Definitely, we need to put the IABP to at least support and see whether the heart is actually right now recovering from that insult. Refractory unstable angina, increased risk of MI is there. So in that situation also, you can think about putting the IABP. Cardiomyopathy, severe myocardial damage because of viral myocarditis. This is one of the indication of your putting IABP. Stabilization post MI, when you are waiting that patient is being posted for the CABG. Elective placement, like you have to put when you are thinking that this patient is having left main disease, severe LV dysfunction, and post-operative congestive cardiac failure. So these are some of the situations where they can keep it in the CCS and put one or two questions related to IABP. So these are some of the questions related to IABP in the CBS. Now, what are the contraindication? More are like related to EDIC 1. because I got a question related to EDIC1 related to this contraindication of IBP. So aortic regurgitation, aortic dissection, severe peripheral vascular disease, aortic stents, chronic end-stage heart disease with no anticipation to recovery, and relative would be uncontrolled sepsis, abdominal aortic aneurysm, severe peripheral vascular disease. That would be, I think, mainly venous diseases that you have to think about not putting, or like something where you do not expect that this patient is going to recover from IBP. Now, what are the complications? Again, some of the CCS what we have gone through, they would make the clinical vignette 3 and 4 related to post-operative cardiac surgery. Patient would be having some of the complication related to IBP. This would be also similar to the ECMO cannulation. So they can keep the third, fourth, or fifth clinical vignette in the CCS, some of the complication related to cannulation. So transient loss of peripheral pulse, limb ischemia, thromboembolism, compartment syndrome, aortic dissection, local vascular aneurysm, making it as a false, hematoma, bleeding, infection. So anything related to the procedural or the catheter related complications. Balloon rupture with gas embolism, helium. This is one of the complication. Hematologic changes, thrombocytopenia, hemolysis, malposition because of something happened during your proper positioning. You are trying to do that. Cerebral or renal compromise. Now, there are certain the clinical situations that you need to be very thorough. It would be very difficult to explain you in limited time, but these are the scenarios where the examiner would be definitely asking you to check whether you understood, whether this is something related to early inflation or late inflation. What would be the things that will happen if you do or inflation at this point of time. So this is early inflation, and that would lead to increased LV oxygen demand due to your increase in the afterload, because you are inflating it prior to the time period at which it should be. Decreased LV oxygen supply as a result of your increased LV oxygen demand due to decreased diastolic perfusion, and as a result, what is happening here? Decreased cardiac output due to decreased stroke volume, because you are unable to actually increase the diastolic perfusion, and there is increased afterload. As a result, there is decreased stroke volume. Now, if it is early inflation, which is not good, again, late inflation is also not good. And here you can see the graph, the curve here. Delayed balloon inflation, what will happen? It is right now not getting inflated only. So that would decrease the diastolic augmentation. The whole purpose of putting the IVP is defeated here. So this would result in decreased coronary perfusion. As a result, what is happening? Our whole idea of putting the IVP is defeated. Now, early inflation, late inflation, that has already gone. Now there is again another situation that would be early balloon deflation. So if we are deflating the balloon like much before, what is happening? Early balloon deflation will fail to improve the left ventricular afterload. And as a result, what would happen? So you can see here that it is not exactly serving the purpose. And late balloon deflation also increases your aortic end diastolic pressure. And again, what is happening? That would increase your afterload as well as left ventricular oxygen consumption. So you are keeping it for prolonged time, the balloon. So as a result, what is happening? It is increasing further the afterload. So the idea, the whole indication of putting the IABP is not getting fulfilled. Now, poor diastolic augmentation, and that would be decreasing the coronary augmentation as well. So we have already seen the first question that it should be 30 to 70% of like your assisted systolic blood pressure, the augmentation. Now coming to the so as a like nutshell, I would say that you have to know related to IABP. They may ask you in the CBS as well as in the CCS, one of the clinical scenario. Now this is something related to the arterial waveform, and they have given you the clue. Sometimes they won't give you the clue related to arterial waveform. They would make all the graphs, the waveforms normal, and they would say that interpret the abnormal waveform. So that becomes little bit again more difficult to identify in limited 1.5 minutes or 2 minutes time, like assigned to this question. So here they have mentioned it related to arterial waveform, so that becomes like the makes our life a little bit easier. And it is pulsus paradoxus. You can see here the cyclic variation. So what are the likely causes? The most common is cardiac tamponade, adhesive pericarditis, severe lung disease, advanced heart failure. So you have to at least give 3 to 4 differential diagnosis, and that should start with cardiac tamponade. They may give you one clinical scenario, 1 to 2 line as well. Now, this is something related to static image of your transthoracic echo. Sometimes they will give you one short clip also, some video clip also. So you have to see as a whole, maybe it would be for 10 seconds, 15 seconds, some of the important findings, and then you have to comment upon. So this echo image would, you can see here pretty well. Your RV is dilated, and that is the main striking feature in this static image. So right ventricular dilatation and dysfunction, and in the diastole the ratio you can see here is more than 1. You can see here RV and LV, the ratio, which is consistent with, you can see that it is right ventricular dysfunction, normal value is less than 0.6. So what is the treatment? So this patient is most probably in acute pulmonary thromboembolism. From this static image, we do not have any clinical finding in this clinical scenario. So acute thrombolysis with altiplase. So it has to be acute thrombolysis. CBS 17, you can see here, this C is related to, you can see most of the people, they could not answer, but yes, this is 2-3 AVF, ST segment elevation with reciprocal ST segment depression. So you have to mention both the two things. It is very easy. People, like most of the students, they answered about this first point, but yes, you have to again mention about the complete diagnosis. Reciprocal ST segment depression in lead V1 to V4, and also the lead 1 as well as AVL, and treatment is PCI, urgent PCI. Now, this is something related to advanced hemodynamic monitoring. We would advise that yes, though we do not use it regularly, this has not translated into the patient recovery in terms of monitoring. But yes, the advanced hemodynamic monitoring is one of the preferred domain or favorite domain in the European exams, because European intensive care units, they use it for the academic purpose or whatever. But yes, they prefer to put 1 or 2 questions from the advanced hemodynamic monitoring, and that is again related to the current, something related to extravascular lung water index, something related to global end diastolic index, so CVP, the systemic vascular resistance index. So this picture, this graph is something is favorite. Now interpret the data. So you can see here there are multiple pictures, multiple values, but the most important things that is striking is SVB, stroke volume variation. Stroke volume variation 17 is really high, and as per the all the important literature, they suggest that if it is more than 12%, it would be definitely the going in favor that this patient needs fluids. So 10 to 12% is the cutoff. So 17% is really high, and you can see here the SBR, high SBR. That is again suggesting that the patient is in hypovolemic stage. Now, patient resuscitated with 10-liter fluid over 24 hours. As the first graph, you could see that the SBP is 17% with SPRI is more than 1800. So you have loaded the patient with 10-liter of fluid in 24 hours. Now what is happening? So the clue here, if I would say, rather than going into all the details, you can see here 2 things that is striking. One is extravascular lung water more than 11.2. The normal is around 4 to 7. So definitely it is striking. And the other thing which is again corroborating to my interpretation is the presence of B lines on the ultrasound focus. So these 2 things would be definitely, I would be going in favor of that. We have overloaded with the fluids here. So fluid overload, extravascular lung water more than 10, pulmonary edema, ARDS. So maybe the patient is going in the ARDS line. Now, the same patient after 2 days, interpret the hemodynamic data. Now, you can see here the SBRI is right now reduced from 1800 to 886. SBP is 4. it is in the, you can say, the plateau phase of your like Frank-Starling curve. So definitely now the patient is in the right, like I can say, stage. SBP is 4, hence optimized fluid resuscitation. SBRI is optimized. So this is achieving the end point of resuscitation. You can see here also in Frank-Starling curve, it is no more in the log phase. Now, there is the question, the ECG. It is very straightforward. Most of the students, most of the delegates, most of the attendees, like examinees, they have answered it very well. Polymorphic VT, and how will you treat? Again, the questions here, we have not mentioned a clinical scenario, but in your exam, preferably in edit 2, they would be giving you a little bit of like a clinical scenario in the CBS as well. So they would mention about the clinicals, like the vitals of the patient, so that you have to go ahead whether you have to start with DC shock, and or you will be starting with magnesium sulfate, see the response, or straightforward go ahead with the DC shock. So something that would be depending upon the clinical scenario, how unstable, how stable the patient is. Now, this is the CT angiogram. So the MRI are right now in, as per the new EDIC, the guidelines or the instructions, I would not say guideline, but yes, as per the instructions shared by our previous candidates, they are not putting any MRI images in the exam. Rather, they would be restricting themselves to the maximum of CT pictures. So the abnormality in the CT angiogram, occlusion of the right MCA, you can see pretty well here. Okay, so this is a straightforward question, but yes, this would be followed by some or other the next question. What would be the next step? How would you monitor the patient? Something related to clinical status. Now, this is something related to ethics. I know in 1 minute, 1.5 minutes, they may not give you something related to critical care ethics, but just for the sake that you may get a similar question in the CCS also, in clinical case scenario towards the end of your like clinical vignettes. The last question, last clinical vignette, normally they deal with something related to patient counseling, communication, end of life care, ethics. So we need to know something about everything. So that's why we try to put this question in our third like the mock test. So 30-year-old male with head injury was on ventilator. So he was withdrawing from painful stimulus. His pupillary responses were equal, and brain CT scan showed bilateral frontal contusion and subarachnoid hemorrhage. Now his blood pressure was 100/60, SpO2 93% on 0.6 FiO2, temperature was 100 degree Fahrenheit, blood sugar was 70 milligram per deciliter. He had been nursed with the head elevated at 45 degree. Now, the ICU doctor has decided that the patient requires a central line and has approached the wife of the patient for informed consent. Now, the wife is apprehensive about the possible complications and wanted to know if you can avoid the invasive procedure and about alternative. So, what the ethical principle apply in this setting? So, definitely here we all know the critical care ethics, autonomy. So, patient has got all the right to know, or the patient family relative has got all the right to know what would be your next step, what are the things you are going to do, what are the possible complications related to that procedure. So as a critical care or healthcare provider, you have to explain to the maximum satisfaction or understanding of the patient or patient family relatives. And non-maleficence is that whatever you are doing, it is for the best interest of the patient. So you are not having any like the wrong intention for the patient's treatment. So that also here applies. So you have got all the, again, the authority to explain that yes, the patient's blood pressure is somehow around the low range, and the patient is having like no traumatic brain injury, and the patient is having some of the complications, or the patient is going into some of the other things that has to be tackled with doing a central line and continuing with the further management. Now, the same patient's ICP continued to rise, and the neurosurgeon wanted to go ahead with the emergency hemicraniectomy, which, according to the treating team, has the best result with good survival if performed early. If performed early, but yes, but the patient's wife doesn't agree with the surgeon, saying that the patient expressed before that he doesn't like to undergo surgeries, which would be prolonging the suffering. So now what will be the next best line of action? So it is again a very important things that normally happens in our clinical practice, that we know that we need to do this procedure or the surgery, but the family is not convinced with the literature or whatever we are trying to explain. So at that point of time, what would be your plan of action and your like state? So here definitely we need to explore the patient's wishes with regard to medical care with his wife. So uh, here we need to think about that we need to respect also the family and also the further plan of like our treatment with the all the possible complications as well as the evidence. Now there are other options: proceed with the procedure without his wife's consent. No, you have to respect the family's decision. Consult the hospital ethics committee. Again, ethics committee, yes, you can do that, but here you have to first discuss with the family relatives. Now consult other members of the family and seek their consent for procedure is not applicable at this point of time, because the next keen would be his wife. Now the last question, yes, it is related to a graph about the procedure which we are supposed to know, and that is related to CRRT. So, 70-year-old man had oliguria 6 hours after the emergency surgery for leaking abdominal aortic aneurysm. The ABG we did, that is showing pH of 7.08, PCO2 5.9 kilopascal. Here I want to bring to your notice that we need to, again, we highlighted in our the all like long course about the 4 months in different domains every week, that you need to remember the normal values in different units. Whether it is in kilopascal, they may give it in millimeter mercury. So in European exam, you cannot question them that we are being trained to follow the ABG or read the ABG in millimeter mercury. They may give you a range 4.7 to 6.0 just to help you out. But yes, sometimes they may skip this and they can just give you 5.9 kilopascal. So you have to know the conversion factors and some of the important things. It's not possible humanly to just go through the conversion factor for all the important like things that we are dealing, all the lab parameter. But yes, the ABG, the glucose, the urea creatinine, the that has to be like understood and remembered by the candidates before going into any like the exam where you have less time to change all those like parameters. Now PaO2 13.5, more than 10.6 is normal. Base excess minus 12. The normal is, we all know, plus minus 2. Serum potassium is high. Urea is 15, definitely high. Creatinine is 300, definitely high. So what type of renal replacement therapy is shown in figure, and what type of you can see the the things that you need to be take caution. So it is continuous hemofiltration, and you can see here.
अरे यार तुम्हारी दुकान से यार
Can you please mute your speaker? Yeah. So again, you the complications that you need to, or the things that you need to be really cautious about, the hepatic dysfunction, low cardiac output, hypocalcemia, hypoalbuminemia, hypothermia. So that are some of the things that you need to be really cautious about, and some of the complications that can happen. So here I want to highlight that there are many graphs and webs. There is a specific station for that. So now everybody is aware of the most common things. So definitely the examiner would be interested to put 2 3 questions in that station which have not been ventured before. So that's why you never know, they can keep or bring any important graphs and curves from their real ICUs. And most of the pictures taken from their own, like I can say, real ICU pictures, like the patients, the graphs, curves. So you won't get it copy pasted from any book in the real exam. So you need to see what are the important graphs and curves and the lab parameters, the clinical indications, the CT scan, the ECG graphs, the ultrasound pictures that can be asked in your EDIC2 exam. And we normally advise, it is like right now high time. We know that it's about to like only 2 days left, but we always suggest that you should have your own question bank related to different domains of CBS and CCS, and that would be your last 7 days task. So you should revise all those things. It's about the revision. It's about the most important thing you should not forget, because you have very less time in the real EDIC2 exam. So with this, we will go to the CCS3. The CBS part we have finished. Now, CCS second has been already dealt by Dr. Sanand. So the last one would be finishing in next 10 to 15 minutes. So this is something related to obstetric critical care. So 21-year-old G1P0 woman at 29 weeks gestation arrives to the hospital because of severe dyspnea of 6-hour duration. Her prenatal course has been unremarkable and she denies of any medical problems. Her BP is right now 160 by 114, heart rate 105, respiratory rate is definitely high, 40 breaths per minute and levered, and saturation is 90%. The fetal heart rate you monitored is in the range of 140 beats per minute. Now, the patient denies prior history of elevated BP. So we need to see here the most important. We have to scan the clinical vignette here, because you have to, because this is the time at which you have to see the questions that can come in the next slide. Now, what are the differential diagnoses at this point of time? So as we always suggest to our candidates, you should have a structure in your mind rather than just arbitrarily telling from like A, then like P, then Q, then Z, then C. Rather, you should always frame in certain structure. So pregnancy related, pre-existing. Pregnancy related, the most important, the first differential diagnosis in this patient would be preeclampsia with severe features. And the pre-existing, it can be preeclampsia superimposed on chronic hypertension, essential hypertension before patient was having hypertension, renal artery stenosis, hyperthyroidism, Cushing's, pheochromocytoma. Though there are not enough clinical data to suggest most of the things, but yes, the first thing that you should not miss, that would be definitely like deviate you from like getting the next clinical vignette sometime. It is preeclampsia. So what will be your immediate next steps? Oxygen supplementation may require ventilatory support because the SpO2 is 90%, patient is having tachypnea, 40 beats per minute and labored. You have to lower the blood pressure to take care of all these, like maybe the patient is having pulmonary edema, patient is having like the hypoxia, diuresis, because you like always think that this patient is in congestive heart failure and pulmonary edema. Now, what are the diagnostic criteria of preeclampsia? Again, very straightforward question. We have deliberately kept it just to make you understand that preeclampsia is one of the like the most important clinical case related to obstetric critical care. You are supposed to answer this, because without this, if you will get a direct question like this, you are definitely fortunate. You will not get a direct question like this in European exam, but yes, most of the candidates, they have answered it well, but again, it has to be a structured answer. Hypertension, systolic blood pressure more than 140, diastolic blood pressure more than 90, occurring after 20 weeks of gestation in a previously normotensive patient, 2 readings 4 hours apart. So this statement should be complete. And 1 or more of proteinuria more than 0.3 gram per 24 hour, protein by creatinine ratio more than 0.3, serum creatinine more than 1.1 milligram per deciliter or doubling, elevated transaminase more than 2 of upper limit, severe headache, thrombocytopenia less than 1 lakh, pulmonary edema, visual symptoms. So if you want to say as a direct question answer to the one of the important questions in your CCS, you have to answer it as a whole. What initial investigation you will ask for? Again, in preeclampsia, we have to mention blood, ABG, micro, maybe it is right now not concerned in this patient, imaging. So we have divided into again a structure. So imaging, microbiology, blood, in imaging it would be again chest X-ray, but here if you want to do it with uterine shield and imaging, it will again cover your ultrasound abdomen for the patients like the overall clinical status as well as fetal well-being, and also 2D echo, ECG, blood, CBC, RFT, urine, routine, LFT, PT-INR, APTT, and ABG. Then coming to the Vignet 2. Now the patient has developed bilateral coarse crackles. S1, S2 are normal, no additional sound, ultrasound showed mild IUGR. Whatever you will tell in the CCS questions answer, that would be in the Vignet 2. So we have done the X-ray, we have done the ultrasound, we have done the ECG, and you are getting the reports like this. The lab report showing hemoglobin of 12.5, TLC of 13,400, platelet is 1,25,000, sodium potassium is okay, calcium is okay, creatinine in 0.9, urea 27, STOT, STPT is slightly elevated, bilirubin 0.9, INR of 1.04, urine protein to creatinine ratio is 0.6, and the X-ray is here. Now, you can see what are the key principles in managing the patient with preeclampsia. Treat severe hypertension should come in the first line. Closely monitor the mother and fetus well-being. You have to optimize the delivery time. You have to prepare the patient as well as your the OT, and also you have to consult with the family and decide about the delivery time. Prevent seizures because the preeclampsia are more prone to develop the seizures and turn into eclampsia, which is not at all advisable or expected at this point of time from a clinical point of view. Continue close monitoring postpartum as well, because it's not only related to the prepartum or the intrapartum, rather you have to also closely monitor postpartum. Now, what will be your immediate next step? It would be oxygen supplementation. May you have to require, the patient will require ventilatory support. You have to immediately lower the blood pressure, diuresis, continuous fetal monitoring. Now, how will you decide upon optimal timing of delivery? One is expectant approach. If the mother and fetus are stable, have no findings of serious end organ dysfunction, we can wait and make the patient and the fetus more viable. Delivery of the fetus, when you have to go for urgent delivery, severe hypertension, serious maternal end organ dysfunction, because you have to now take priority for your the mother. Non-reassuring tests of fetal well-being, when you are not sure that this patient's fetus is actually right now doing well, but yes, you have to save the mother first. What will be your fluid strategy? Standard question, restrictive fluid strategy, monitor for organ dysfunction. You have to assess, not it's a static parameter, rather we have to go ahead and repeatedly do it by 2D echo, lung ultrasound, straight long leg raise test. May be unreliable at this point of time because of compression of the the IVC, because the fetus is there, and type of fluid is crystalloid. Those aliquots of fluid, you cannot advise 500 ml, 1000 ml as a whole. Monitor the cardiac output by bedside advanced hemodynamic monitoring if it is allowed and permitted in your ICU, or you are well versed with the advanced cardiac output. Here you have to do that because you have to take care of the mother as well as the fetus. End point of your hemodynamic monitoring or adequate organ perfusion are urine output, patient's GCS or mentation, lactate, capillary refilling time. What monitoring will you advise? Again, continuous vital monitoring for the patient, ECG, SpO2, respiratory rate. These are standard vital monitoring. Invasive arterial monitoring, BP monitoring, cardiac output monitor. Then related to fetus, continuous fetal well-being monitoring by fetal heart rate monitoring or cardiotocograph. Fluid intake output monitoring. Which drug agents can be used to treat high BP in pregnancy? Labetalol, hydrogel, nifedipine, methyl dopa. These are very straightforward questions, but we want to just highlight that you need to be thorough and you have to answer it just 1, 2, 3, 4 in the examination. What is the target BP? Reduce mean arterial pressure by no more than 25% over 2 hours to achieve your target blood pressure of 130 to 150 systolic, 80 to 100 millimeter diastolic. Because if you will be aggressively reducing the blood pressure, that would definitely hamper your fetal perfusion, and also that would be not advisable in terms of reducing it to avoid the end organ perfusion well. Do not reduce blood pressure below 120 by 80 because it would be detrimental to the patient's recovery. Now, coming to the Vignette 3, she was started, as you have already told in the CCS, like the Vignette 2, started on IV labetalol. You have given like small dose of your furosemide, oxygen support, and you have thought about the fetal well-being and maturity. So you have given steroid. Now the patient is being planned for a delivery. But next morning, she is found to be confused. Her blood pressure is still 160 by 100, but she has no gross motor deficits on neurologic examination. Now, what are the differential diagnoses at this point of time? Again, you have to divide into pregnancy related, eclampsia, preeclampsia, which is not getting relieved, and HELP syndrome. Then you have to also think about, you cannot just blame eclampsia or preeclampsia for all the your management related issues. So you have to think about, is my patient is having something unrelated to the eclampsia and preeclampsia typical diagnosis. So it can be press related also, because the patient became drowsy. Hypertensive encephalopathy, that would be also another differential diagnosis. CBT, cerebral venous cyanosis thrombosis, subarachnoid hemorrhage, because of the blood pressure high. Now, what will be your next steps? ABC, standard answer, injection magnesium sulfate, neuroimaging, taking neurology consultation at this point of time immediately, and you have to again think about going for urgent delivery. You cannot delay further. Now, what is the dose of magnesium sulfate? What is its therapeutic range? This is expected from you. You have to just answer loading dose of 4 to 6 gram of a 10% solution intravenous over 15 to 20 minutes, followed by infusion. Then 4.8 to 8.4 would be its therapeutic range. And again, you have to remember in the millimole per liter also. So the conversion also you need to remember. And what is the role of magnesium sulfate in your pre-eclamptic patients? Seizure prophylaxis. Now, what are the features of magnesium toxicity? This can be just related to your eclampsia, preeclampsia, as well as related to your ECG also. That can be one of the questions related to hypomagnesemia, related to a refeeding syndrome. So you have to again divide and make your answer in a structured way. Serum level more than 4, serum level more than 10. Then what would be the ECG? Just as for a hyperkalemia. So as per the serum level, the features would be different. So you have to remember that. Then again, hyperkalemia, typical hyperkalemia changes also would be also similar for the hypermagnesemia. Increased PR, QT complex, prolonged QRS, peak T waves, flattened P waves, complete AV block, and asystole. Though it looks easy in the current discussion, but I would bet when you are getting questions in the real exam and you do not have time and you are having that stress factor, people fumble in the real exam. So we always say that you cannot dare to miss or get it wrong for the simple questions, because that would be disastrous for some candidates, because they would take some average. So it would be something related to percentile, because if everybody has answered this question right and you are making it wrong, definitely that is not a good thing for any candidate when he or she is in the borderline. Now, how will you treat magnesium toxicity? General principles: dialysis, the definitive treatment, calcium chloride, 10% in 5 to 10 ml repeated, and forced diuresis. Forced diuresis, IV normal saline, furosemide, and watch for hypocalcemia, which can make symptoms worse. And the antagonist is magnesium is calcium, that you need to remember. Now, coming to the clinical vignette 4, she delivers a low birth weight child via vaginal delivery after induction of labor. Gradually, her neurology condition improves, which is expected with regaining of full consciousness, but her BP is still remaining in the range of 160 to 170 systolic and 90 to 100 millimeter mercury diastolic. So they have again made the thing complicated, continues to make the case complicated. Now, is there any change in your antihypertensive regime between intrapartum and postpartum? No, it would be remaining the same. Target blood pressure is 140 by 90, and now you have to advise for continuous telemetry, the blood pressure monitoring. Which antihypertensives should be avoided in lactating mother? Again, beta blockers are not advised at this point of time because the patient is lactating. Angiotensin receptor blockers, methyl dopa, because the patient is lactating. What are the effect of preeclampsia in long-term maternal prognosis? Recurrence risk, increased risk for related obstetric complication in future pregnancy, that definitely you have to mention in your discharge summary, and increased risk for cardiovascular and renal disease because the patient continues to have your like the blood pressure high, and that would definitely affect the cardiovascular system as well as renal system. So this would be a normal flow of questions if you are getting a case or CCS or like the CBS related to obstetric critical care. So the first one discussed by Dr. Sanant, and this is something we thought of putting it so that you can cover the two important domains. And with this, we come to end of our discussion for the two CCS as well as 25 CBS. We tried to cover most of the important domains we have already covered in our regular course one mock test CCS as well as CBS before, and there are almost 10 domains we have covered in last 3.5 months. So enough questions. We have almost 25 CCS we have covered in last 4 months, and again almost 150 to 200 or more than that CBS questions covered just for the sake of practice, because it's ultimately how confident you are, and it should not look like you are facing the examiner for the first time and you are completely amazed that the examiner is asking questions we do not know how to answer, how to frame your answer, how to make it structured, and how to look the examiner with confidence, because it's the confidence, I would bet, that would be the most important thing in the real exam. And your answer should be smart. Don't be confused if you are unable to answer from your clinical case scenario or vignette 1 or 2. You may miss 1 or 2 important questions. I have taken few the delegates the attendees examination, and I would definitely share with remaining candidates, because there are many candidates from different countries here who are appearing this debrief for the first time. The face value is very important. After not answering or unable to answer 1 or 2 questions, you get so dejected, your look becomes so dejected. Sometimes the examiner gets that feeling that yes, this candidate is not very much confident in handling this type of complication in the real ICU. So though maybe it won't affect your, because it's all mechanical, if you answer it then they will take it, but it gives little bit of edge over for the examiner to not give the answers or the marks in little bit of the things that you expect, that yes, my answer was right but the examiner didn't give me the marks. So if there are no questions, is there anything the candidates, because we are finishing it, so best wishes for all of you, and we feel that we have tried our best in last 4 months or so to make you confident. That is our first goal. Then well versed with all the domains, that is your second goal. Third goal, that what are the things that is normally asked, and the feedback from our candidates, previous batch candidates, because that is again most important thing, where the normally the candidates actually face problem in the real exam. And there are certain things that we normally advise in the last debrief before the examination days, that your internet should be very strong and you should be that day free of every stress. And we do not want you to be mugging up the questions or answers in the last night before your exam. Make yourself stress free, because the examination is all about mind game. When you have already spent your critical care training for 2 years, 3 years, 5 years, you have already appeared maybe the last exam also, but we do not want you to face the examiner with stressed mind. And again, we want to share this slide with all of you. Maybe you all, if you want to register for upcoming exam, because there are many queries from different candidates from all over the world, when is the registration or the course for the spring session 2024 is starting. So we are starting it from 16 January. I would say the course starting date is 16 January. It is not the registration date. We would be starting the registration earlier than this date. We would be having a free introductory class also. like how should be your approach, what should be the books that you should read, and how you should start from day one, and what are the things, what are the tips and tricks that you should follow from day one, so that at the end, maybe before the exam date 7 and 8th May, if we will meeting for the final debrief maybe on 4th or 5th of May, we should not be confused at that time. So it is better that prevention is better than treatment, and we want to prevent that. You should not be stressed maybe after 3 months or 4 months. Thank you, all of you. And Dr. Sanant, you want to share anything before we conclude?
No, I think you have covered everything, Tapas. So best of luck for the candidates and keep us posted about what was the exam, how did it go, and what are the questions. So we'll be in touch with you guys after the exam, and hopefully all of you should pass the exam. And my best wishes. Thank you.
Yeah, so again, keep us posted. You can write to us, you can share your like concerns to us, you can share your feedback also to us, and we'll definitely try to help you in your future endeavors for any of your critical care queries, or like your training or anything like that. We have multiple courses, we have multiple programs for the better training and teaching of our critical care. Thank you. Thank you. Best wishes for your exam. Make all of us proud, and we are definitely hoping that you should all clear your exam. Thank you.
Thank you. Thanks, Tapas.
Thank you. Thank you, Dr. Sanand, for staying so late for your the
Right.
day. Okay, bye.